appetite is reduced. Thirst for 4 to 5 glasses of water per day, that is not much, okay, it is. Urine is quite normal. Stool has to go twice with unsatisfied feeling. That is quite abnormal. Craving for salty things, sour things, mutton, farsan, that is chura, ghatia, wafer, all like that, and spicy food. Aversion to milk, digestion poor, retrosternal burning, no flatulence, perspiration on the margins of the hair, no smell and no stain. That means what? From here, all the sides of the hair, the perspiration would come. Sleep, 8 hours of refreshing sleep, starters in sleep, salivation in sleep, cramp in the calf muscles during sleep, dreams of water, and in the menstrual cycle, first menstrual period 15 years of age, regular menstrual period 5/28, flow normal with reddish clotted discharge, no smell or stains. Before menses, there's backache, pimples on the face, and during menses, no complaints. Patient is ambithermal. Mentals, there is suppressed grief, very much, which forms the core of the case. Patient is extremely sensitive, very emotional, likes consolation, however, is very also obstinate by nature and aggravated by the least contradiction. Patient feels better in company. Extroverted personality, religious nature, fastidious, and very fearful. Fear of dark, lizard, thunder, lightning, heights, and memory is quite good. Okay, general examination. Patient is conscious, cooperative, well-oriented, time, place, and person. Temperature afebrile, pulse 80 per minute, respiratory 20 per minute, BP 100 by 80 mm of Hg, pallor is present, and other symptoms like icterus, cyanosis, clubbing lymph, they all were. Cystic examination, per abdomen, tenderness in the epicacid region, in the right region, left lobe of liver palpable, all the other symptoms were quite alright. Investigative report on 2011-98 shows antibodies to hepatitis C virus positive, SGPT increased, urodynamic 1 enteritis with ankle gastritis, and USG shows specific. So the diagnosed disease is antipeptic disease with antibodies to hepatitis. Now the reasoning is probable this hepatitis C she must have got from tooth extraction 6 to 7 years back, and then it's been in the right hypochondrium. It's a dull aching in nature, restlessness, tenderness, aggravated by taking allopathic medicine, symptoms were worse, and lab investigation shows hepatitis C virus positive, and uronoscopy shows grade 1 esophagitis with gastric, with enteral gastritis. Okay, now, so this is the case. So we have to now see whether the susceptibility is high or whether it is low or whether it is moderate in between high and low. So now how to work out the case on these 7 points. So first point is the symptom exhibited. So out here, as you all can see, the symptom exhibited, most of the symptoms are characteristic in nature, because I've written +3, +2, C cravings, C aversions, C in the chief complaint also, the aggravations, the ameliorations, in sleep also, in menses also. All these are symptoms which are characteristic. So you are getting characteristic symptoms on the mental level, on the physical level, as well as the particular level. And the pathology is also extremely well defined. Okay. Now, nature of the case. So in this case, it's a chronic case, which is well defined. Well defined meaning what? Symptoms are characteristic on mental, physical, and particular levels. And the symptoms we are getting more features are present, which includes the pathology also. Now, pathology involved, it's a reversible pathology with structural change. The fundamental miasm is generally tubercular because you go for the family history and also supported by the past history. If you would evaluate one by one all these points, you would see tubercular miasm is more prominent. Or then the sensitivity on the mental level is high because you're getting good symptoms pertaining to emotion, good symptoms pertaining to the will of the patient or behavior of the patient, and also at the physical level, also you're getting the symptoms pertaining to craving, aversion, appetite. This is characteristic. Please mute yourself. What is every time? Don't tell you that. Please mute yourself for the background. Then history of suppression. So out here it is absent because, as I said, the patient was on allopathic treatment, which made it worse. And as I told you, that's a misnomer. It cannot be taken for suppression. For suppression, there has to be a shift because energy is there. It cannot be destroyed. It can only be transformed from one place to the other place. So out here, there is no basic shift I'm seeing anywhere. So suppression is absent. And how will I confirm it? Suppression is absent. I will confirm it from the symptoms. That the symptoms exhibited are characteristic in nature. However, if suppression was there, then generally speaking, as I told you, you would get paucity of symptom or you would get just common symptoms. So this way also you can counter check whether you're on the right track or you're on the wrong track. Okay. And the general patient is quite good, as you all can see. The TPR was also all right. Patient was well oriented, time, place, and person. So now, if I sum up all these points, the susceptibility will be high. See, I'll again tell you, symptom exhibited, they are characteristics. So now what conclusion? Now, so from each point, we have to come to a conclusion. Now, symptom exhibited, they are characteristic, therefore, susceptibility is high. Nature of the case is a chronic case, but it has well-defined characteristic symptoms. So therefore, susceptibility is high. Pathology involved, reversible pathology, structural change, susceptibility high. Fundamental miasm, susceptibility is high. Sensitivity on the mental and physical level, it is high, so therefore susceptibility is high. And suppression absent, therefore susceptibility is high. Gender connection patient is good, susceptibility is high. Therefore, all these 7 points you are seeing, susceptibility is high. Okay, so in a case, it could be 4 points are for high susceptibility, 3 points are for low susceptibility. So therefore, overall susceptibility will be high. So this is what, as I told you, the summation of all the 7 points have to be taken into consideration. You cannot say only on one point that the patient is exhibiting PQRS symptoms, so susceptibility is high, or the patient is a young patient, so susceptibility is high. Patient is an old age patient, susceptibility is low. Sorry, you cannot work out the susceptibility on this 1 or 2 points. You have to work out the susceptibility on the summation of all these 7 points. Now, next we go to the second prescription. Now that's the next part in your syllabus also, and I'm sure you all must have been taught in your UG days also. If not, I will again tell you, or there'll be a quick revision into the same. So the definition, it is the one that is made after the first prescription is correct and it has acted and has been left alone. So basically, the second prescription can be defined as the first prescription when it has acted. So naturally, the first prescription, generally speaking, is a correct prescription because we take it for granted that whatever medicine we have chosen in the first prescription is the similar. So therefore, it is the correct one. It has acted and it has been left alone. That means what? It has acted and we have allowed the medicine to unfold its action to the maximum extent. Okay, so if the first prescription has not acted curatively or is not permitted to act the full time, it is impossible to get the second observation. So also very important that if you do not give enough time for the first prescription to act at its full time or the full length, that means what? You're in a hurry to give the second prescription, then you will spoil the case. So whatever deep acting constitutional remedy you are given, and if it is acted curatively or it's a correct medicine, and you have to give sufficient time for the medicine to unfold its action, then only you'll be able in a position to observe the second observation. If status quo after based on the first prescription, the next remedy given is still called the first prescription. So that's also very important. Okay, so I told you, second prescription is the first is made after the first prescription has acted. This is very important. The word acted is very important. So if I give the remedy, patient comes to me again after 15 days saying that he's status quo or there is no relief in the symptoms, then the next prescription or the medicine which I will give after retaking the case will still be called the first prescription and not the second prescription. Why? Because the patient was status quo. Patient has not improved at all. There was no change occurring in the state of the patient. So the remedy has to act in some way after the first prescription. Then only the next remedy will be given is called the second prescription. That means what? The remedy what you have given either has to have an aggravation or an amelioration. That means what? It has to act in some way. That means what? There has to be some reaction of the organism towards the medicine which has been given. Then only the next prescription, what you give, will be called the second prescription. Okay, so this is important because the Viva, they'll ask you, that if at all the patient, after you give the first prescription, patient is not better, I give the remedy B. So remedy B is called the first prescription, or is it called the second prescription? Okay, so you have to answer that. If there is no change in the patient, remedy B is called the first prescription. However, if there is a slight change in the patient, remedy B is called the second prescription. So this is important to remember. It has to act in some way or the other. So difficulty arises when the patient changes the doctor. Now, if you read the Kent's book on philosophy, it tells you that the difficulty will arise when the patient is satisfied with the doctor and he changes the doctor. In the first examination, the records of the patient have to be carefully studied. So when he changes the second doctor has to have a good information on the first examination or the records of the patient, or they have to be studied carefully. Thus, the first physician will only be competent enough to make the prescription. So naturally, if you do not have proper insight into all the records of the patient or the first examination findings, then you will not be in a position to judge the second prescription. So for this, naturally, the first physician who the patient has contacted will be only competent enough to make a second prescription. Therefore, the second prescription whom the patient has, the second physician whom the patient has consulted, not be in a position to make a second prescription no matter how much medica he knows. So Kent has also said that the second physician who the patient has seen will not be in a position to make the second prescription because he doesn't know the first examination made by the first physician. The medicine that has partly cured the patient can often finish it, and the medicine will not be changed until reason change. So the first physician has given the medicine, and if it has acted and it has partly acted curatively, then remember this remedy is the correct remedy. It will definitely pave the way to cure, and you have to then administer the medicine either in a single dose or multiple dose stimulation, depending upon the case. Okay, and you should not change the prescription until there's a good reason for changing it. Generally, what do we do when the medicine doesn't act? We think our totality is wrong. We go on changing the prescription and we go on giving one medicine after the other medicine, and as a result of which we totally bungle up the case or we totally spoil up the case. Okay, so therefore, remember that whatever medicine had been given for the first prescription, and if it was acted partly curative, then remember that this medicine is the correct medicine. It will definitely furthermore also help the patient. Therefore, the full record keeping the patient on the previous doctor has to be bought in order to perceive the case correctly. So therefore, if you want to perceive the case correctly in depth, you have to have the full record, case taking record of the first physician. Then only you'll be able in a position to know what medicine has been given, how long the physician has waited, has he waited long enough, or was he to give the prescription, as a result of which he spoiled the case. It is only after a tedious and thorough inspection of all the symptoms that an intelligent physician will be capable of making a second prescription. So therefore, you have to study the case properly, which has come to you from the other physician, by requesting the other physician to give you the notes, what he has taken. So therefore, an intelligent physician only after a thorough and this inspection will be in a position to make a second prescription. Thus, if the first prescription has been beneficial, it should be allowed to act to its fullest extent. So if the first prescription is acting well, then don't be in a hurry to repeat it. Just give a placebo, just wait and watch. So how will the second physician be in a position to judge this? So now the dilemma is there that how will the physician, the second physician rather, be in a position to judge it? The rule to judge is how many symptoms have been removed by the first correct prescription and what has only common and trivial symptoms may still remain. So therefore you have to see after the first prescription is given, how many symptoms were removed or these symptoms were ameliorated. However, you may just get some residual symptoms. They are known as common and trivial symptoms may still remain. So if majority of the symptoms have been ameliorated and only a few symptoms which are not very specific or unspecific symptoms are there, then you know that and you know that you're on the track. So don't in a hurry to prescribe, but wait for the return of symptoms and then prescribe. So do not be in a hurry to prescribe. You have to wait for the symptoms to resurface, which have disappeared under the action of the first remedy. As I told you, the rule for repetition is that merely a cessation of progress of the case is not to be taken as an indication of repetition, but however, we only repeat it when the symptoms have disappeared. Action of first remedy, they again reappear. Okay, so therefore, don't be in a hurry to prescribe. Wait for the return of symptoms and then prescribe. So therefore, early repetition and long continued giving the same medicine will prevent an opportunity for making the second prescription. So therefore, the first physician could be quite hasty. He could again repeat the medicine, or he's giving the medicine 3 times a day, 2 times a day for weeks and months together. Okay, so this also you will not be able to identify what will be the second best prescription. If the doctor administers a well-chosen remedy and repeats it too soon, he will never give the symptom the chance to come back and call for a second prescription. That is also very true that if the minimum is given or the doctor administers a remedy well, what happens? The chosen medicine and he repeats it too soon. Okay, so you have to wait. Don't be in a hurry to prescribe. Wait till the symptoms completely unfold this action. Then only, and wait for the symptoms to come back. Then only you can prescribe or go on for a second prescription. If enough time is given, say example, days, weeks or months, one can really make an observation upon the return of original symptoms, which is the first thing to be considered. So you have to wait patiently for days, weeks or months for the return of the original symptoms. If, however, new symptoms come up while treating the patient at once, see the pathogenesis and see if the symptoms belong to the drug administered, patient is proving the drug. However, if old symptoms resurface, you know that you're on the right track. If new symptoms resurface, or not resurface, or new symptoms come up in the case, you have to see that whether these symptoms are there in the pathogenesis of the drug. If so, then the patient is proving the drug. So therefore, you have to see, you ask the patient if the patient has symptoms, or patient will tell you that doctor, these symptoms are there, which I have not experienced before. It is the first time which I'm getting the symptoms after I've taken your medicine. Okay, so if it's the first time the symptoms are coming up, see whether it is in the pathology of the drug. That means if it is there, that means he's proving the drug because quite probable you are repeating it too often. Okay, but if the patient says that, doctor, after taking the medicine, whatever symptoms I had 2 years back, they have again resurfaced or they have again come back. Or if the patient doesn't tell you that, you have to ask the question that, have you ever suffered from these symptoms in your life before? Okay, so tell the patient to recap many years back if these symptoms have occurred. If so, you know that there's a return of the original symptoms, you know that you're on the right track, and you know the cure will definitely take place. However, if new symptoms are come there, patient has never experienced the symptoms before, it's the first time he's experienced the symptoms, then you know that you're on the wrong track, he's proving the symptoms. Rather, he's proving the drug. Okay, so this is short about the introduction. Now let us see what points it includes. So the first prescription will include repetition of first, change of potency, change of remedy, use of antidote, alteration of remedies, use of intercurrent remedy, use of isopathy and nosode, use of mass remedies, and the indication of use of placebo. Now, what I've underlined, Kent has only told you these 3 points which I have underlined. Okay. So, repetition of the first. The only indication of repetition of the first is indicated with symptoms that have disappeared under the influence of the remedy. Again, that I've already told you that. Remember that repetition is done should, okay, that means as I told you, cessation of progress of the case is not an indication of repetition, but when the symptoms which have disappeared under the action of the drug, they again reappear, that is the only indication for repetition. Remember that repetition should be done in the same potency and also same dosage as the first prescription. So whatever you're repeating the drug, suppose you have given 30 potency and only 1 dose, you do the same action to be followed. Then a mere cessation of progress of the case is not an indication for repetition, which I've told you. Also, in the appearance of old symptoms, do not repeat the first remedy. So if the old symptoms reappear, you just give a placebo, do not repeat the remedy. Do not repeat the remedy. If you repeat the remedy, the full case will be spoiled and the patient will not be cured. Also, remember, if the old symptoms, if they persist and do not disappear on their own, then only repeat the first remedy. But this is very rare. Generally speaking, when there's a return of the old symptoms, just give a placebo, wait and watch. The symptoms will disappear on its own because the vital force is quite capable of taking care of these symptoms. However, as a very rare instance, if it persists and it doesn't disappear, then only you again have to repeat the first remedy and see whether the totality still hold good for the first remedy. But this is a very rare instance, I'm saying. Okay. But generally speaking, when the old symptoms come, give a placebo, they generally disappear on its own. Now, change of potency. It is indicated when the remedy has exhausted its action and is not capable of producing any further beneficial action. So, in the change of potency, meaning what? That the patient comes to a status quo, there is no further improvement. Whatever improvement has taken place, it has taken place, and the patient is stuck at that improvement. There is no further improvement taking place. For example, patient is 60% better, and still after repeating the medicine, also the patient is 60% better. There is no further improvement. It is difficult to judge in the hands of beginners, but easily done in the hands of experienced homeopathy physicians. So, as your experience increases in the field of homeopathy and when you treat many patients, you will come to know when to change the potency. But however, in neophytes or in persons who have just graduated from the homeopathic medical college and they practice, it may be difficult for them to judge when to change the potency. So a judgment of the case and reaction observed has to be actually correct for good result. So your judgment should be perfect, and also the reaction observed. So a judgment will be got through experience itself. However, before going over to the next higher potency, try multiple dose stimulation of the same potency. Okay, now one point here. I mean, you all can ask me one question, that how do we know when to change the potency? Of course, it is a judgment through experience. That is beside the question. But in the hands of beginners, what you can do, you can safely again repeat the same medicine A, for example, in the 30th potency for 1 week and call the patient back for a follow-up. If the patient tells you, no, doctor, again, I'm only 60% better, there is no further improvement taking place. So that time, you know, the potency has completely exhausted its action, and now is the time to switch over to the next higher potency, that is the 200 potency. So in the hands of beginners, if you're not sure when to change the potency, just repeat it, repeat the same medicine. If the indications are there for the same medicine, you repeat that. Or if the indications are different, you take the totality and you choose a second best medicine, and you then give it in the higher potency. So in the hands of beginners, just repeat the same medicine in the same potency and see the reaction. If still no reaction, patient still status quo, then you know you have to go into the next higher potency. But this judgment will come as and when your experience increases. However, before going over to the next higher potency, always try multiple dose stimulation of the same potency. As I told you also that don't be in a hurry to change the potency. If you're giving a single dose, just try multiple dose stimulation. When the highest potency in a particular scale has been reached and there is no longer, and the case no longer improves, again start with the low potency. This will establish the reaction and the case will progress further in a positive direction. That means what? When, while treating the case, suppose you have used the highest potency in the centesimal scale, and then there is no further potency to go because that's the highest potency. Okay, so you have given 30, 200, 1M, 10M, 50M, then MM, DM, DM potency. There is no potency to go. But still the patient requires medicine, still the symptoms are still persisting. So what do? In such instances, you again go back to the low potency. You again start with the low potency. So you have given the maximum potency and there's no further potency to go to, again start with the low potency. By doing so, what will happen? The reaction of the case will improve and the case will progress in a positive direction. When you employ a nosode in low potency, which causes an undesirable aggravation, then administer the next high potency, which will. So generally speaking, nosodes are never given in low potency. But however, if you have given in low potency and there's an undesirable aggravation, then what do? The same has to be given in the next high potency. However, the views of Roberts and Keynes have to be kept in mind regarding the change of potency. So Robert had said that do not change the potency as long as it is beneficial to the patient. So as long as the patient is being benefited by the potency, do not change the potency. This is Robert's view. But Keynes' view is what? He's saying that do not repeat the same potency for more than 2 times. Suppose medicine A, you're given 30, you call the patient for a follow-up in 15 days. You again give remedy A 30, call the patient follow-up 15 days. So then you mustn't give. So the third time patients come to follow up, you mustn't give remedy A 30. Then go to remedy A 200 potency. As you all know, Kent was a high potency prescriber. Okay, so he went changing the potencies very fast. Result of which the duration of the illness got less, and the patients were also benefited and cured in the shortest possible time in a most gentle manner. Okay, and one more point I would like to tell about this potency changing is Margaret Tylers ascending scale of potency. As you all know, Margaret Tylers was a student of Dr. Kent, and she also introduced this potency known as the Margaret Tylers ascending scale of potency. In that, what she said was that those cases which were very obstinate or which did not respond to the treatment, in spite of the totality remaining the same, she said, you have to use my method of the ascending scale of potency. That means what? Say for remedy, example, indicated remedy is A. So on the first day, you give remedy A 30 potency, second day, remedy A 200 potency, third day, remedy A 1M potency. So 30, 200, 1M, ascending scale of potency, you're giving it. So in this, by doing this, the reaction is observed or the reaction starts of the patient and the patient will improve. So in those cases, which are very obstinate, not improving, you can definitely try this Margaret Tylers ascending scale of potencies. Now, change of remedy. The main indication of change of remedy is that when symptoms change, the remedy changes, provided the patient has not improved. This is also very important that when to change the remedy, naturally, if the symptoms change, then also the remedy changes. But the most important point is that the patient has not improved, or patient has become status quo. However, the change in symptomatology has to be definite in order to change the remedy. So there has to be a definite change of symptomatology, then only you can change the remedy. If there is no proper change of symptomatology, if only 1 or 2 symptoms are changed, and if still the first medicine is indicated on the totality, you have to still give that. But however, if there's a major change in symptomatology and the symptoms do not match, with the totality of the drug A given previously, then you know that you have to change the remedy because the symptoms have changed. So remember, a minor change in the symptoms have to be ignored. So whatever minor changes are there, just ignore it. But if a major change is there, then the new total symptom has to be taken into consideration. In general, when the next remedy is selected, it should be complementary to the first remedy, or remedy that follow well should be taken into consideration. So remember that when you are changing the medicine, you have to take a complementary medicine. Complementary medicine is what? Which will finish the task of or the unfinished task of the first medicine. Okay, so there are many medicines or having the remedy relationship table of complementary, follows well, inimical, antidotal, and duration of action. So you have to remember that whenever you take the next the change of remedy, see that it is complementary to the first remedy or it follows well. And also remember that when you change the indicator remedy, the next remedy should not bear an inimical antidote or inimical or antidotal relationship. That is also very important. So in your remedy relationship table, in Gibson-Miller's table of remedy relationships, you may also see those medicines which are complementary, those also come under antidotal or inimical. So do not give that medicine which comes under these columns. Say for example, Calcarea carb. So if you see Gibson-Miller's table under Calcarea carb, the complementary remedies are belladonna and Rustox, which you all know. The remedies that follow well are nitric acid, borax, Kalibai, Epicac, Lycosilica, and there are many other more remedies also. Inimical remedies, again, nitric acid, baryta carb, sulfur, do not follow after Kalibai. Antidote, again, nitric acid, Bryonia, camphor, Epicac, Nux, Sepia, and sulfur. So you're seeing nitric acid is the remedy which follows well as inimical as well as antidotal. So do not give those remedies which have an inimical or antidotal relationship. This is also just one example. You can open your Boris Mathematical. At the end of it, the Gibson-Miller chart is given, and you can see that also for your reference. That is for remedy relationship. Or you can use the Zaha cycle, sulfur, calcarea, Lyco cycle, or Nash's trio of remedies there. That also you can use as a classical example of remedy relationship. It is worth remembering that when the case ceases to progress any further and before you try to change the remedy, the management history or load has to be taken into consideration. So this is very important. If at all the patient has come to a status quo again, and you also change the potency, still the patient has come to a status quo, then you see that is there any miasmatic block in the patient, or you see the miasmatic load in the patient through the predisposition of the patient, that is through the fundamental miasm. If so, a nosol should be introduced, which often restores sensitivity to the constitutional remedy. So if obstacle is there, then generally a nosol is given in a high potency, infrequent repetition, and then after giving the nosol, you can again introduce the constitutional remedy. For example, say constitutional remedy is Calcarea carb and patient, and you have increased the potency, still patient hasn't improved. Then you have eliminated all the other causes like the diet, the regimen causes, exciting causes, precipitating causes, or the maintaining cause. So the only cause which is remaining now is the fundamental cause obtained from the family history and supported by the past history of the patient. So suppose you're getting a psychotic miasm and it calls and the medicine medoranum is indicated, then medoranum has to be given 1 1 dose, and then you again repeat the constitutional medicine Calcarea carb in 200 potency, 1 dose or multiple dose stimulation, and the reaction will be observed. So Dr. Dhawale, he has said that these both remedies can be given at one time because the miasmatic block also will be removed, and the constitutional medicine will be taken care of, and the action of constitutional medicine also will be will go on further the moment the obstacle has been removed. So we are giving Calcarea carb 200 3 times a day. We just interpose medoranum 1 1 dose at bedtime, and we continue. Okay, so this is Dr. Dhawale's view on that, not Hahnemann's view. Is Dr. Dhawale's view on that. Okay. Now, use of antidote. So in homeopathy, you can antidote reactions that are unfavorable to the patient. So now, which reactions will you antidote? Number 1, new symptoms which appear in the case. Actually, if new symptoms appear in the case, as I told you, see whether the new symptoms are there in the pathogens or remedy. If so, then you have to immediately stop the medicine and antidote. For a severe aggravation by the first prescription, the first prescription is there and the patient is totally aggravated, then also you can antidote. Or if killer's aggravation, Ken's first observation, prolonged aggravation with final decline in health of the patient, also known as killer's aggravation, in which you have given a high potency, may or may not have repeated it frequently, but there is an irreversible pathology and the susceptibility of the patient is quite poor. So in such instances, do not give high potency and just give the indicated medicine in the 30th potency, one dose, wait and watch. Some people are also of the opinion, the practitioners I'm saying, are also of the opinion that if you want to avoid killer's aggravation, do not give the similimum drug. You give a partially similar remedy and not the similimum. This will help not to have an killer's aggravation. That means what? You give a similar remedy and not a similimum. Meaning what? For a similimum, the medicine should be taken on the totality of symptoms. It should be repeated in the correct potency and the right repetition should be there. So these 3 points have to be there. Whereas in a similar remedy, it has the first point, that is, it is conferred by the totality of symptoms, but the problem is either in potency selection or in repetition. So here the problem occurs, you haven't selected properly the medicine on basis of, or rather you haven't administered the medicine on basis of potency or the repetition. Okay, so this is the practitioners, this is what they are saying, that in practice, if you want to avoid this, give a partially similar medicine and then you will avoid the killer's aggravation. And then later on, when the susceptibility was low, which then comes up or which gets it rises to an appreciable level, then that time you can give the similimum again in the 30 potency, one dose, wait and watch. Okay, this is not in the books. This is what the practitioners are saying. Just for your information, being PG students also, you should know this. Symptoms disappear opposite to Harry's law of direction of cure. So naturally, if it goes in the wrong direction, if the symptom disappears in the wrong direction, also you know that you have to immediately stop the medicine and antidote. Or when disease travels from the periphery to the center, the disease goes more deeper into the organism, also you have to antidote. Then alteration of remedies. It is considered in acute cases where the symptomatology alternates between two definite groups. So in acute states, say for example, a case of say joint pains, okay, in which the totality revolves around Rustox and Brownie. Both of them are quite indicative, okay, and you're not in a position to fix which drug is more indicated, either Rustox or Brownie. In such instances, also you can give in alteration Rustox and Brownie also. This also Dr. Hahnemann has also advocated. He's saying that in acute cases, you can alternate remedies and you can treat the patient. Why? Because in an acute state, it is an emergency. We have to give the patient immediate relief. In order to get immediate relief, you can use one or more than one remedies in an acute state. But Hahnemann has made it very clear that in a chronic case, alteration of remedies will not work, because a chronic case is because of a deep-seated constitutional defect in the patient, which has to be treated by the constitutional remedy. He also says that those cases which come on, or those symptoms, or those cases which go on coming up repeatedly, again and again, then also alteration of remedies will not work. In such instances, you have to go for the constitutional remedy only. This Hahnemann has made it very clear in his writings, in his greater writings. Also, if you read Richard Hughes's book, he's also mentioned the same point about what Dr. Hahnemann has mentioned, that he has said that Hahnemann has experimented in acute cases because of emergency, have to give relief, so alteration of remedies can be considered. Okay. In chronic case, a single remedy capable of covering both the states have to be selected. As I told you, chronic case, it's the deep-seated constitutional defect, so you have to go for the constitutional remedy. If it covers only one state, then it will not cure the case. However, the routine administration of remedies in alteration has no justification. So in routine, in your daily practice, you cannot alternate remedies as a routine, but only in which you want to give immediate relief to the patient. There's an acute exacerbation or an acute case, immediate relief has to be obtained. Yes, then you can definitely go for alteration of remedies. Otherwise, in chronic cases, it is not allowed. So read Richard Hughes. Also, he has given a reference of this also he has given. Now, use of intercurrent remedies. In a chronic case, when the case gets blocked and refuses to make any progress. So when there's any blockage to the case, you can use a nosode or an intercurrent medicine. Determine the miasmatic block through the symptomatology of the case. Administer a suitable anti-miasmatic remedy, generally a nosode. It will remove the block and the case will start responding. Okay. So it may be quite so that whatever medicine, the civillimum, whatever you have chosen, it hasn't covered up the miasmatic activity of the patient. So you have to choose a remedy which will have the same anti-miasmatic effect. Suppose psora is there, you have to give an antipsoric, basically an intercurrent remedy which will help the patient. Now, use of isopathy and nosodes. Okay. Now, isopathy, it was introduced by Johann Joseph Wilhelm Lux. Wilhelm Lux. Okay. And not William Lux, which you all go and sing in the exam. This is the right answer. Johann Joseph Wilhelm Lux. Okay. When the indicated homeopathic remedy fails to ameliorate the person who is allergic to some chemicals or drugs, produces allergic reaction in a person. So when isopathy is used, when any drug or chemical which the patient takes, it produces an allergic reaction to the patient. So such an allergic reaction can be taken care of by the use of isopathy. In such cases, the same chemical or drug administered after potentization is known to cure the person. So you can definitely potentize that remedy or that chemical and give it to the patient, in which you can use the isopathic method. Sometimes this method is also useful because sometimes you may give the acute remedy, you may give constant remedy, still it doesn't work. Then you can try the isopathic method also if the patient is allergic to some chemical or drug. Now, nosode. The indication of use are there. The nosodes can be used as constitutional medicine. Okay, so it is not necessary that a nosode is only used as an intercurrent medicine. It can be used as a constitutional medicine also, like medorinum can be used as constitutional medicine. Tuberculinum can be used as constitutional medicine. When the well-selected remedies do not act, so in spite of your best efforts, you've taken the case very well, still the patient doesn't react, then you can also select a nosode. This is another indication of nosode. Or patient has never been well since the last attack of bronchial asthma, or since I've eaten ice cream, after that I've never been well, I'm getting repeated cold and cough. So never been well since also may call for an indication of the nosode. And generally they give high potency and not frequently repeated. Kent has said that always never give it below 10 m. Give it 10 m and above. Other authors say give it 1 m and above. And very few authors say give it in the 200 potency. Okay. Sometimes it can be solely indicated on inhaled related from smallpox, measles, or influenza. Sometimes you can use a nosode also, ailments from smallpox, measles, or influenza. So such remedies, ailments from smallpox, variolinum, measles, morbillinum, and influenza can also be administered. Now, use of miasmatic remedies. Use on the basis of miasm present in the case. If administered, it will clean up the case or it will remove the obstacle to cure. And important of dominant and fundamental miasm. Which I've told you that in an acute case, you have to take the acute miasm, that is a dominant miasm. In a chronic case, you have to take the predisposed patient, that is the fundamental miasm of the patient, into account. Now, placebo, as you all know, placebo is a substance which is given for the gratification of the patient. So the various forms of placebo are sugar of milk or cane sugar, globules, tablets, biscuits, and cones. So you can dispense by any of these methods. The commonest one being the globules. Now, indication for use of placebo. The most important is that when you're not able to decipher the correct remedy, or you're confused between two seemingly similar remedies. So better not to give the indicated medicine, or not to give the medicine when you're not very sure, because our medicines are dynamized. They act on the dynamic level, they act at a more deeper level. So it is quite dangerous to give a remedy which you're not sure of. So Dr. Kent has also said that giving patient allopathic medicine would be preferable rather choosing the wrong homeopathic medicine, because the allopathic medicine doesn't act on the dynamic plane. The homeopathic medicine acts on the dynamic plane, goes more into the deeper level. So therefore, a wrong medicine will cause more harm to the patient, and it will be difficult to remove the bad effects of wrong prescription of homeopathic medicine. Or a placebo can be given, especially when a new case is there and it requires some investigation. So for the first time, if you're lucky, you may get a patient coming to you for the first time, and you may still require some investigations. Say, for example, you're suspecting renal calculi, or you're suspecting tuberculosis, whatever it is, you want to investigate the patient and see more and see exactly what is wrong with the patient, and then from the diagnosis or cases which are complicated and they require repertorial analysis, or cases which are very complicated. Again, it becomes difficult for us to find out the constitutional medicine, and you want to repertorize the case. Naturally, you will not refer the case in front of the patient, give a placebo, and call the patient after 4 days, and by the time you can do repertorial analysis. Okay. Or when you're not sure of the correct medicine, or you're not sure, as I told you, between two remedies, you're not sure what to be given. Or in cases when there's homeopathic aggravation. So when homeopathic aggravation takes place, also you can give a placebo, and in mental complaints, when one dose of constant remedy is given. So in mental complaints are there, suppose dysmenorrhea is there, and you are giving a constitutional medicine a few days prior to it, then you have to give the placebo. Okay, so that's all today for today. Whatever topics in your syllabus, I finished all of that. And I also got my YouTube channel by the name of Homeopathy Super Sessions by Dr. Jagos. It's a channel related exclusively to Organon. It's easy to understand and remember. I've explained the videos in very simple language, taken only all the important features and have explained it to you. It contains all important topics of UG and PG syllabus. Also, it has 72 videos, or rather 73 videos up to date today. Also important tips how to crack the examinations, viva questions, theory questions, and much more. And also I've introduced the short prescriptions in commonly seen diseases, in which in my 32 years of practice, I have prescribed these remedies for many a times, and I've got good results. So this also I'm sharing with you. So if you like, you can subscribe to my YouTube channel. There are many videos I've put up regarding your UG and PG syllabus. You can definitely go through that and also learn. Okay, so that's all for today. Are there any questions which you want to ask? I can answer it. So we overshot the time anyway. Are there any questions to be asked? Okay. Okay, one more. Can you see this? What I've shown? Sarla Sonora Member Seminar. Can you see this?
Yes, sir. Yes, sir.
So if you want, also, I can give you the details of it on the WhatsApp group of Dr. Mrs. Desardas Madam's WhatsApp. I can also give her the details of it, and then she can share it with you. So on this Saturday and this Sunday also, we have got the Sarla Sonora Memorial Seminar. It's a virtual seminar in which good speakers are there, and they will tell you, how for rapid and acute prescribing in homeopathy. I'll just play one small video about the same.
So it was a very nice interactive session. Respected Dr. Jagos sir, may I have this vote of thanks session, sir? Good afternoon, sir.
Yeah, good afternoon.
So, I, Dr. Darak, on behalf of Guru Mishra Homeopathic Medical College, PG Department, respected Dr. Desada Madam, Dr. Yogesh sir, and Honorable PG Director Dr. Tufan sir, as well as all the coordinators, Aishwarya Madam, and all our PG guides, I would give a vote of thanks to Honorable Dr. Jagos sir. As Dr. Jagos sir is a teacher of teachers and master of masters, sir has been contributing to the faculty of homeopathy since a long, and he has been delivering such a knowledge and lectures as a part of National Journal of Homeopathy, as well as a honorable member of D.Y. Patil Institute, as well as through his homeopathy practice. He is devoting for the cause of homeopathy for the well-being of human being. Once again, I would thank Dr. Jagos sir to give such a nice lecture presentation on remedy administration, potency selection, second prescription, including placebo and remedy relationship. It was really a nice session, sir. All of our PG, we have enjoyed it. Thank you very much, sir, on behalf of the Mishra Homeopathic Medical College.
Are there any questions? Anyone wants to ask any questions?
If any questions are there, PGs, please come on. Sir is interested to answer your queries. Anybody?
Okay, fine. I don't think any queries are there. And whatever doubts I had, people have written in the chat also, they are being cleared. So fine, I'm happy to note that also.
Thank you very much, sir.
Okay, welcome.
Thank you.
Well, bye everybody. Bye.
Thank you.
Thank you, sir.
Thank you.
Bye, sir. Thank you.
Bye bye, sir.
Thank you, sir.
Yeah, welcome.
Thank you, sir.
Welcome.